we will be going in MCQ wise. So try to answer the questions. I will try to explain to you, and if there is a controversy, I will try to solve that controversy. Even if there is some doubt from your side, just ask me now. Right. So in breast conservative surgery, the healthy margin excised. What is the healthy margin that is excised in a breast conservative surgery? Normally. Yes, audio, please check the audio. Right? 1 centimeter, 2 centimeter, 3 and 5. Yes, go through your answers. You have to tell answers, you have to shoot up your answers. There is nothing wrong in saying a wrong answer here. But you have to say something. 1 centimeter, right, still. Okay, yes, majority of times we take 1 centimeter as a margin. Okay, in normal, what is breast conservative surgery? When you call it as breast conservative surgery, when you do a breast conservative surgery, when you plan for a breast conservative surgery. Of course, in carcinoma you don't plan a breast conservative surgery. Yes, in situ or likely, okay, when there is some premalignant risk, but still it is benign. What is this breast conservative? So breast conservative surgeries are most likely wide local excision, quadrantectomy. So you are trying to preserve some part of breast. Okay, of course, you know the therapy called as quadrantectomy plus radiotherapy. Okay, in wide local excision, along with the tissue, you take a 1 centimeter margin to see that entire tissue is removed. Okay, this is for the safety purpose. 1 centimeter margin is normally taken, and one more breast conservative therapy is quadrantectomy, where you remove one quadrant and of course you give a radiotherapy later on. Lymphatics from the left upper quadrant of breast drain into all of the following groups of lymph nodes except. Of course, it is quite obviously very clear, it is parasternal. Now, let me know what are the lymph nodes that are present. Lymph nodes of the breast. The levels of lymph nodes of the breast. Bird's classification. The levels of lymph node of the breast is classified based upon Bird's classification. Okay, first, what are the lymph nodes of the breast? Yes? Axillary group of lymph nodes. Next, internal mammary group of lymph nodes. Yes? Supraclavicular group of lymph nodes. Okay, generally these are the common group of lymph nodes. Now, axillary group of lymph nodes are again divided into 5 groups. What are the groups of axillary group of lymph nodes? Anterior, posterior, lateral, central, apical. Okay, this is the order. Anterior, posterior, lateral, next we have central and then apical. Okay, so these are the axillary group of lymph nodes. 75% drain into this group of lymph nodes. Internal mammary group of lymph nodes are there, where 20% drain and of course rest drains the 5. Now, what are Bird's classification of lymph nodes in breast? We have again, this is a different classification. Axillary, internal mammary is different classification. Bird's group of classification is different. This is based upon the levels, level 1, level 2 and level 3. Level 1, level 2, level 3. What are the group of lymph nodes which come under level 1? How we classify these levels? What is the structure based on which you classify these levels? Pectoralis minor, right. Now, level 1 consists of below pectoralis minor. Level 2 at the level of pectoralis minor. Level 3 above, right. Now, what are the group of lymph nodes which are present in level 1? This axillary group of lymph nodes. Okay, majority of this axillary group of lymph nodes are present in level 1. Level 2, The most important group of lymph nodes in level 2 is interpectoral. What is that called? Rotor's nodes. Yes, this is important. Rotor's nodes. Yes. Okay, this level classification is important regarding this lymphatic drainage. Now, whenever you want to remove, you have to see that you remove level 1 and level 2. Okay, minimum level 1 and level 2. If at all it is a highly malignant or you have a high suspicion that lymph nodes are involved, you have to see that level 3 is also involved. So that is the basis why we classify. At least level 1 and level 2 you have to remove. Okay, that is regarding the levels of lymph nodes. Okay. Now this is the drainage of this quadrants of the breast. So here it is draining into, this is the upper outer quadrant and this is the outer inner quadrant, outer quadrant, lower outer quadrant and upper outer quadrant. This generally drain into the axillary group of lymph nodes, and this inner quadrant they drain into parasternal group of lymph nodes. Right. Okay. This is all regarding that. The most common site of metastasis for breast carcinoma. Yes. Vertebra, thoracic or lumbar? We have two types of vertebra here. Yes. Why? See, breast is surrounded by thoracic vertebra. Why it will go to lumbar vertebra? Now there should be some reason, right? Generally, anywhere in the body, cells tend to gravitate down in any vessel. Okay, for a metastatic deposit to occur, there should be a stasis of cell. So where does stasis occur? Stasis will not occur in the thoracic vertebra. Cells settle down and settle in the lumbar vertebra. And to facilitate this settling, there is a plexus called as venous plexus, Batson's venous plexus, a valveless veins, which directly allow the venous column. Generally, veins have valves, so that these valves close and the cells settle down there itself. But these Batson's venous plexus are valveless. So what happens? The cells come and directly settle down in the lower post part. So lumbar vertebra becomes the lowermost part. So most common deposits and settling will occur in this region. Right. Secondary deposits from the carcinoma of breast are commonest still. Yes? Same question repeated. Bone, right. Okay, this is the venous plexus that you have, and this is the Batson venous plexus. Okay, which settles or which holds all the metastatic cells. Okay. Signs seen in large duct papilloma. What is the most common sign seen in a large duct papilloma? Nipple discharge, breast mass, thin excoriation and lymph node involvement. Nipple discharge. Yes. What is the most common cause of nipple discharge? Of course, it is a large ductal papilloma, that is the most common cause of nipple discharge. What is the most common cause of serous discharge? The most common type of nipple discharge is serous discharge. Okay, duct papilloma is the most common cause. What is the most common cause of bloody discharge? Yes, not carcinoma. Okay, remember, whenever the term bloody is used, don't be a cinematic way and resemble that it is a carcinoma. No. Again, most common cause is papilloma only. For all discharges, most common cause is papilloma, except for green discharge, ductectasia. The most common cause for a green discharge is ductectasia. Other than that, it is the duct papilloma which produces the most common discharges. Right. the most common presentation of duct papilloma in breast is? Yes. Okay, all discharges, remember, it is the duct papilloma which directly secretes into the duct that produces the discharge. The papilloma secretes all the secretions into the duct that comes out, okay, through the nipple. So the discharges are most commonly seen. Okay, pathological nipple discharge is mostly associated with. Again, one more question. Okay, so what is this ductal papilloma? What is duct papilloma? Is it a benign condition or a malignant condition? Benign condition, yes. Okay, it is the most common cause of serous or bloody discharges, and mostly it is a proliferation of the epithelial cells of the duct. Okay, there are some epithelial cells that are present in the duct. See, this is the duct, and there are epithelial cells which are present in the duct which proliferate and form a small papilloma. Okay, the secretions of this come out through the nipple and are common and are the most common causes of secretions. And how to identify duct papilloma? How do you identify a duct papilloma? What is the investigation that you do to identify a duct papilloma? How to identify? Whenever there is any discharge, what do you do first? Whenever there is any discharge from the nipple, what is your next line of investigation? Yes? Cytology. You do an FNAC and do the cytology, and cytology determines whether it is a papilloma or not. Okay? You do a cytology. Now, how to treat this duct papilloma? Yes, the treatment is called as microdocotomy. Right? You remove this duct per se. Just only the duct, not everything around the duct, just only the duct. That is called as microdocotomy, is ductectomy, like removing the duct. So microdocotomy, that is a duct march. Okay, this is a case of intraductal papilloma. Now, one more topic. Most common presentation of lobular carcinoma is breast mass. Mammographic calcifications. Incidentally, a patient comes or a woman comes with a screening, just for screening, and she just finds out some microcalcifications. Will that not be a lobular carcinoma? Yes, right. So majority of times lobular carcinoma will not have calcifications, right? So breast mass is the most common presenting feature, and majority of times invasive lobular carcinoma or lobular in situ, these are multifocal and multicentric. Okay, what is multifocal? What is multicentric? Yes, if there are one or more tumors within the same quadrant, then it is multifocal. Okay, within the different quadrants it is multicentric. If it is in the both breasts, then it is bilateral. So most commonly lobular carcinoma presents as multifocal or multicentric, and majority of times they are difficult to detect on mammography because they don't have calcifications. Calcifications are very less. Calcifications are more commonly seen in DCIS. Of course, macro calcifications more commonly seen in DCIS, not LCIS. Right? Okay. The pattern that is present commonly, make a note of these points, these are very important. The pattern of microscopy of lobular carcinoma, where there will be concentric patterns, a concentric circular patterns that is called as targetoid appearance. A typical targetoid, like a targetoid appearance of concentric circuits. And there is E-cadherin negativity, loss of E-cadherin. E-cadherin is one important structure which, when it is at loss, has got more tendency for metastasis. I think you know that E cadherin is a structure which forms cell-to-cell interactions. When there is a loss of cell-to-cell interactions, you get more metastasis, and which is more or high risk for malignancy. So loss of E cadherin mutations will be seen, and most likely you will be identifying by IHC, immunohistochemistry positivity. Okay, the patterns is targeted pattern. This is very important for this. So this is a case of Indian filling targeted pattern, blue color. Right. False about lobular carcinoma breast. Good prognosis? Yes. Yes, it is good prognosis. But when it is a good prognosis for lobular carcinoma? What you have to do for making it as a good prognosis? See a patient, let me ask you one more question regarding this. A patient presents you with lobular carcinoma with multicentricity and a foci of bilaterality. That means lobular carcinoma is seen in both. Okay, a multicentricity is seen, but a foci of bilaterality. There is just a suspicion that it is present in the other breast also. Now, what is your treatment of choice? Your treatment of choice. Bilateral mastectomy, simple or MRM, modified radical mastectomy. I think you know the types of mastectomies. You want to do a prophylactic simple mastectomy or a modified radical mastectomy. Yes, bilateral. When you are talking a term called as prophylactic, you do only simple mastectomy, right? So prophylactic, bilateral, simple mastectomy is the treatment of choice. Okay, that is to be done. When that is done, the patient has got very less risk for malignancy and has got a good prognosis. Okay. One more important question which is commonly asked. PD orange appearance of breast is due to, yes, obstruction of the superficial dermal lymphatics. Now, infiltration of the Cooper's ligament, what does it cause? No, this is PD orange appearance. Again, if you say PD orange appearance, puckering or skin tethering. Okay, fine. So remember, infiltration of Cooper ligaments, that is tethering. Here PD orange appearance is orange skin peel appearance, which is because of the dermal lymphatic infiltration. Right. You have to identify this picture also. Now, drug of choice for estrogen receptor positive breast cancer. Tamoxifen, anastrozole, tamoxifen. Okay, no, I am just making to get confused, because confusion starts only in the exam. Outside the exam, everything will be clear. Only confusion will start in the exam. Now you will be thinking much more than abnormal levels that what you think. You will try to perform abnormally in the exam. Okay, then confusion starts. Okay. So management of breast carcinoma, very clear management of breast carcinoma. You have, again, based upon the stages. Generally for stage 1, the common thing that we do is a lumpectomy or a breast conservation with a radiotherapy like quadrantectomy with radiotherapy. Stage 2 and stage 3, what is the normal thing that you do? MRM, modified radical mastectomy, is the standard procedure that we do for stage 2 and stage 3. Stage 4, advanced chemotherapy, hormonal therapy and radiotherapy. Okay, this is the general protocol. Now what are the types of MRM that we do? Types of MRM that we do. Yes, we have 3 types of MRMs: Patties, Scanlons, Auchincloss. Yes, 3 types of MRM. Now, what is a Patties MRM? What is an Auchincloss MRM? What is a Scanlons MRM? What we do in each? Yes. Whenever you retract the pectoralis minor, okay, and then release it. Pectoralis minor is intact. Just you retract and then release. Austrian clause. Retract and release is Austrian clause. Scissoring, that means cutting, is scanlons. Patties, completely remove pectoralis minor. You cut pectoralis minor, remove the lymph nodes and then attach. That is scanlons, just scissoring. Okay. Patties is completely where you remove. Okay, you remove as the pectoralis minor and then you do your surgery. Okay. I thought someone was asking some doubt. Okay. Now, indications for radical mastectomy. One thing that you have to remember is what are the indications for radiotherapy, what are the indications for chemotherapy. We'll just discuss the indications when you have to do chemotherapy. Now, what is the one point you have to tell whenever you want to use chemotherapy? What is the first point that you have to tell? What is the first indication that you have to remember? Yes? Receptor positivity, you give hormonal therapy, not chemotherapy. Hormonal therapy is there. Now, when do you first use chemotherapy? What is your idea of using chemotherapy anywhere, not only in the breast, anywhere? Yes, you want to downstage. I can give radiotherapy and shrink the tumor. That is also possible. The point that you have to remember whenever you have to give chemotherapy is, if the node is positive, if the node is positive, then you have to give chemotherapy. Why? Because it has crossed the sentinel site and has spread to the body. You want to treat the entire body, give chemotherapy. When you will know that you want to treat the entire body? If the node is positive. So the first indication for chemotherapy anywhere, for any carcinoma, node positive means it has spread to all the body, so you have to give a chemotherapy. Right? So a positive node, negative node but more than 0.5 centimeter, negative node with greater risk. See, higher risk of malignancies with negative node, still there is a chance, so you have to give. Negative node with hormonal receptor negativity. Whenever there is hormonal receptor negativity, you don't have an option of giving hormonal therapy, so give chemotherapy. So these are the general indications of chemotherapy, and particularly 0.5 centimeters, more than 0.5 centimeters is considered to be a positive lymph node, and risk, high risk and hormonal negativity, you have to go with chemotherapy. Okay. When do you use radiotherapy? Okay, before going to that, when do you use hormonal therapy? When it is receptor positive. Nice. When you use radiotherapy? Now, the indication for using radiotherapy, let us make it clear. Whenever there is a local disease, so radiotherapy is given to a localized part. So, whenever there is a local disease, try to confine, give radiotherapy. Systemic disease, chemotherapy. Localized disease, radiotherapy. Okay, right. So, the indications for radiotherapy commonly we use for breast conservative surgeries. Quadrantectomy, you remove the quadrant and give radiotherapy to the localized thing, so that some amount of tumor, if it is still left, that will be damaged. Okay, all the tumor cells will be lysed. So radiotherapy is mainly used for localized parts. Chemotherapy is used for systemic. Now, the contraindications for radiotherapy are more common, or more commonly asked questions. What are the contraindications when you should not give radiotherapy? This is a generalized contraindications. Yes. Pregnancy is one absolute contraindication. Yes. And previous history of irradiation. Once irradiation is given, complete fibrosis will occur, and again radiation is very difficult to give. So pregnancy and previous irradiation, people who have history of collagen diseases or autoimmune diseases, right? Autoimmune and collagen diseases, again you have to see that Yes. You have to see that radiation therapy is contraindicated. Okay. The important indications and contraindications you have to remember. Now, sentinel lymph node biopsy is not done in C, yes, B, YB, YC. What is the sentinel lymph node for carcinoma penis? Name of the lymph node. Cabanas lymph node. CABANA. Cabanas lymph node in the inguinal region. We have a horizontal and vertical group of lymph nodes in the inguinal region, right? The first lymph node in the horizontal group, that is reactive and inflamed in carcinoma penis, that is called as Cabanas group of lymph node. That is one more sentinel site where you have to look. If that is positive, it has spread systemically. So carcinoma colon, you don't have a specific marker. Okay. Now you have to remember what are the lymphatic drainage of carcinoma colon. What is the lymphatic drainage of carcinoma colon? There are 4 groups of lymph nodes, but still nothing is sensitive or nothing is positive, but there are 4 group of lymph nodes. See, this is the colon and this is the central part. Again, ascending colon, descending colon. This is the central part of the artery, superior mesenteric artery, inferior mesenteric artery, which supplies the colon. Now, the 4 group of lymph nodes are epicolic group of lymph nodes, paracolic by the side of group of lymph nodes, principal group of lymph nodes, intermediate group of lymph nodes. Epicolic, paracolic, intermediate and principal. These are the 4 group of lymph nodes that are present, which are commonly positive in a case of carcinoma colon, but you don't get a sentinel lymph node. Okay, one thing or a specific lymph node will not be there. So these are groups of lymph nodes. So you have to have an idea. Now the sentinel lymph node for carcinoma of breast is, yes, axillary lymph node. Which group is the most common site, or which group forms the most common sentinel lymph node? Yes, anterior axillary group of lymph nodes. Again in melanoma, we have a sentinel lymph node most commonly seen in the inguinal region. Okay, melanoma has the metastasis through this, and we have the sentinel lymph nodes in the inguinal region. We have to examine the inguinal group of lymph nodes for melanoma. Okay. In breast conservative surgery, which of the following investigation is required? Yes? Of course. The simple thing, if you want to treat it as conservative, you have to see that it is node negative majority of times. Histological variant of breast carcinoma with best prognosis. Yes. Best prognosis. So tubular and mucinous carcinomas are the least aggressive carcinomas, followed by coli. Least aggressive first is tubular. Next actually mucinous and colloid at the same order. Mucinous and colloid. Next comes serous. Serous carcinoma is a bit more malignant. Tubular is less malignant. Now, one more standard question. Triple assessment includes all except. Yes. The option will also be the same. Majority of times bone scan only. What is the age of routine screening mammography? One more screening. 40 years. Now, if a patient has BRCA1 positive, what is your screening management? When do you start your screening if the patient is having a family history of BRCA1 positive or BRCA2 positive or some risk or yes 18 years. You have to start from 18 years. Now, what is the investigation modality that you use? Investigation modality CT, MRI. Yes, most likely you will be using MRI. Okay. Now, the screening modality, when do you do the screening? After 40 years you generally do the screening, right? Now, when do you do the screening normally? A self breast examination is advisable for everyone. Now, when do you do this? What is the ideal time of doing a self breast examination? Yes, post menstruation. Why? Okay, when the estrogen levels are its highest level, because ER positivity everything can occur, so you will have a more chances of palpating the mass. Now, that occurs most commonly on the 5th day, 3rd to 5th or 5th to 7th day. Some different books have mentioned, but 5th day is a common. So let us make it sure that it is 3rd to 5th day or 5th to 7th day. Now, what is the ideal position of doing a SBE, self breast examination? Sitting with arms compressed over the flanks, supine, prone. I have given 4 options. SBE. Sitting with hands compressed on the flanks, supine, prone. Yes? Sitting. Hands compressed on the flanks? No. Yes, it is supine. Okay. Supine position is the best for SBE. Not as advocated in the advertisements. Not standing in front of the mirrors and examining. No. You have to always palpate for a mass against a hard substance. Like you have the thoracic wall, when you fall supine, okay, you can palpate against the thoracic wall, which will be more clear. So supine, 5th day after menstruation is the most common. Right. After 40 years, every 2 years clinical examination plus 2 views mammogram. That is the screening modality. Every 2 years clinical examination plus mammogram. Less than 40 years we have examination every 3 years clinical examination plus SBE, self breast examination monthly. Material. These are most likely just some important points. If you have, I think you will be given the questions later. Okay, some theory explanations you can make a note. Now, for high risk surveillance, mostly you do MRI. Investigation of choice for high risk breast carcinoma in female, MR. All are true regarding Paget's disease. 97% associated with underlying invasive carcinoma of breast, 50% are HR positive, wedge or punch biopsies taken from the nipple for diagnosis, underlying tumor lying within 2 centimeters from the nipple. Or 50% is more or less? More than 50% you have positive, less. Okay, I will just discuss about, let's discuss one more question regarding Paget disease. 1% associated with underlying invasive carcinoma of breast, HR positive, poor prognosis, punch biopsy taken for nipple. Now take time, read the question. Okay, so majority of times it is an underlying breast carcinoma which presents as a Paget disease of nipple. Okay, it is a variant of breast carcinoma which presents as a Paget disease of nipple. Which of the following is primarily disease of nipple and areola complex? Paget disease. What is one more disease which affects the nipple and areola complex of the breast? Not cancer, I am asking. What are the diseases which affects mainly the nipple and areola complex of the breast? One is eczema. Next, ductectasia can affect, but not exactly nipple and areolar complex, particularly. Syphilis, okay, where there will be chancre, okay, the ulcer can appear on this, okay, we have syphilis and lepra, not routinely seen nowadays, but syphilis, lepra can also occur in the nipple and areolar complex, and we have Paget disease and of course eczema, okay. So Paget disease, majority of times we have an underlying carcinoma there, and in cases of positive estrogen progesterone receptors, the overlying Paget disease is negative for these receptors, okay. Negativity is more common, right. Now how to differentiate between Paget disease and eczema? What are the differences between Paget disease and eczema? Yes, laterality. Eczema is majority of times bilateral, okay, fine. Next, you have itching, vesicles, papules, everything seen in eczema, where Paget disease is absent, yes. And one more important differentiating feature is involvement of the nipple and areola. Nipple is involved first in Pagets, whereas areola is involved in eczema. Nipple, of course, Paget disease, I think you know the picture. Cells will be coming out from inside and then involving. So nipple will be involved first in Pagets, whereas the surrounding skin, this will be involved more commonly in areola. Surrounding skin will be involved more commonly in areola. Okay, right. So maximum risk of invasive breast carcinoma is seen with yes, you have some important abnormalities with their risks. So you have to remember this. This is very important. So non-proliferative lesions, sclerosing adenosis, intraductal papilloma, and general hyperplasia or florid hyperplasia, where there will be less risk. But these things you have to remember. Whenever there is a term called as atypical hyperplasia, that has got increased risk. Now, ductal involvement by cells of atypical cells, which has got more risk, and the lobular carcinoma in situ or DCIS has got very high risk. So atypical hyperplasia has got a very high risk than the others. Breast reconstruction surgery, which of the following structures is preserved? Which of the following structures is preserved in breast reconstruction surgery? Pectoralis minor, pectoralis major, serratus anterior, and nipple area complex. For all breast surgeries, you preserve pectoralis major first. You don't remove pectoralis major anywhere. Serratus anterior you can remove or you don't remove later. Whenever you want to reconstruct, there should be some basement over which you have to reconstruct, right? If you want to take a flap, where will you put the flap on? You cannot directly put on the ribs. You have to put it on pectoralis major. You want to do some implant, okay, into the pectoralis major muscle only, you put the silicone implant and expand it. Okay, so for all the things you have to have a basement, and the basement is pectoralis major, which you should never remove, right? So pectoralis major is to be always preserved. Serratus anterior of course has to be preserved, but still in some cases if you want to remove, you can remove. Superior lateral boundary of axillary dissection in a case of MRM. Yes? Artery. Okay. Axillary vein, not artery. It is the axillary vein which forms the boundary of the superior lateral. Okay. You will get first vein only. Inside the vein you will have axillary artery. If you want to see axillary artery, you have to ligate the vein, cut and see. So the superior boundary is axillary vein, superior lateral boundary. Now, What is the medial boundary of axillary dissection? See, this is the axilla. What is the medial boundary of the axilla? All the structures has to be removed. What is the medial boundary? Yes? There is nothing. Chest wall. First rib and chest wall. What is the posterior boundary? Up to where you have to dig. What is this muscle that is present here? Of course, scapula will be there. Above scapula, you don't shave the scapula. What is the muscle? Latissimus dorsi. Okay, you have to say, have a picture. So this is axilla. So this will be the chest wall. Posteriorly, you have floor. The floor is formed by latissimus dorsi. Laterally, superior-laterally, you have axillary vein. So all the structures within this should be removed. Now this is the part of axillary dissection. Okay. So the main important marker is the superior lateral marker, which is the axillary vein. Now, conservative surgery is not done in breast carcinoma. When you don't do a conservative surgery, lymph node metastasis, subareolar lump of size 4 centimeters. This is involving the lower quadrant only. Not done. Conservative breast surgery is not done. Okay, it is not done. Lymph node metastasis you generally don't do. Subareolar lump, do you do a conservative surgery? Subareolar lump. Do you want to do a conservative breast conservative surgery for a subareolar lump? Yes, can be done. Okay. Lump of size 4 centimeters. This is involving the lower quadrant only. Yes. Majority of times, no. Don't worry about the answer. The answer is A. But answer can be B also. Most of the times in a case of subareolar complex you don't do. But very rare cases you do. But here answer is A. Okay. Most likely for all the subareolar complexes you don't do a breast conservative surgery. Very rarely. That is called as central excision. Very rarely done. But for lymph node metastasis you never do. Okay. The answer is A. Now, why you are worried about the subareolar complex? Why you are worried about subareolar complex? What is the thing that is making you fear about subareolar complex? What is the thing that is making to always remove subareolar complex? Anyway, you are not going to preserve the nipple and areola. That is not our main motto. Now, why you are worried? Why you are feeling nervous to preserve nipple areola complex? The structure that is present behind it is called as subareolar plexus of Sapi. You have one plexus called as subareolar plexus, where all the breast lymphatics will come and form a plexus. So, any lymphatic from any quadrant of the breast, any lymphatic from any carcinoma, whether it is present at any site, so will come and will get mixed. So, you have to remove. So, even if it is upper outer quadrant, here it will be there, here. Anywhere it will have connection. So, if you want to remove any of this, you have to remove this. So, that is the reason why you generally don't spare nipple and areola complex, because of the presence of a plexus called as subareolar plexus of Sapi. SAPPY. Okay. Breast conservation surgery is not generally suitable for tumors more than 5 centimeters. For tumors involving the nipple areola complex generally. For tumors with extensive intraductal disease, collagen vascular disease, previous radiotherapy again you should not do, because you cannot give radiotherapy again and again, and women who do not have the motivation for breast conservation, who are afraid that cancer may recur, okay, you should not do breast conservation, you have to remove that. the pain along medial aspect of arm in post-mastectomy patient is due to? Yes, which nerve gets injured? ICBN, intercostobrachial neuralgia, right. So this is the common area where you get this neuralgia, this area, this axilla and this area is the common area, intercostobrachial nerve. Here it supplies. So this is the intercostobrachial nerve and this is the area where you get on the chest wall and in the medial aspect of this hand. Okay. The lateral cutaneous branch of T2, that is the intercostobrachial nerve, mainly innervates the anterior chest wall, the upper back, the torso and the nipple. Okay, these are the areas where you get paresthesias. Now, we have other type of breast pains also, phantom breast pain. Phantom breast pain. Of course, what is phantom? False perception. Even though the patient does not have breast, she will be feeling like breast carcinoma still is there, that mass is there, that pain is coming, a shooting like pain, stabbing like pain is there. Okay, so that is phantom breast pain. Intercostobrachial neuralgia is also called as post-mastectomy syndrome, where you will have pain in the axilla, medial upper arm and anterior chest wall. Axilla, upper arm and anterior chest wall. This is the site of the supply of ICBN, intercostobrachial nerve. Okay, that is also called as post-mastectomy neuralgia. Neuroma pain. Neuroma pain most commonly occurs due to radiotherapy. These are the types of pains not given earlier. Okay, just make a note of these things. Neuroma pain is commonly seen after radiotherapy. Nerve not damaged in breast surgery. Quite obviously, we don't. Okay, what is median nerve? What are the muscles which are supplied by median nerve? Of course, anatomy question. Leverous nerve, right? So, what are the structures? Main structures which are supplied are the flexors. Okay, the flexors. We have to do some work, means the median nerve should be activated. So, if you are having a damage to the median nerve, you cannot flex. So, that it should not never occur. So, you can sacrifice all these things, but never a median nerve. Okay. The normally injured nerves during this. Axillary nerves, majority of times the motor nerves present in the middlemost part. The long thoracic nerve, thoracodorsal nerve, medial pectoral nerve and intercostobrachial nerve. These are the nerves that are commonly injured during breast surgeries. The long thoracic nerve supplies. Long thoracic nerve supplies. Serratus anterior, thoracic nerve of Bell. Thoracodorsal nerve, latissimus dorsi subscapularis. Okay. Now, increased chances of breast cancer is seen in which conditions you get a high risk for breast cancers? Early menarche. Okay. This is the most common cause where you find this breast cancer. So, increased duration of estrogen exposure is associated with increased risk of breast carcinoma. Early menarche, late menopause, nulliparous, all these are increased risk. Okay. True about cystosarcoma phyllodes. Cystosarcoma phyllodes. Which of the following is true about cystosarcoma phyllodes? Cystic components, tendency to recur, calcifications, all of the above. See the answer? No? Right. So, what is cystosarcoma phyllodes? What is the importance of this? Tell me one point regarding cystosarcoma phyllodes that you commonly. Yes? Large breast. Okay, one of the cause for a large breast. where you see a bossylated surface. That is the typical term used. Okay, shiny bossylated surface over the breast. Now, why we call it as a sarcoma? Cystocarcinoma phyllodes, why it is not called? Why you call it as a sarcoma? Yes? Yes, it is not epithelial in origin. Very good. If it is epithelial in origin, majority of times it is carcinoma. If it is mesothelial origin only, then it comes under sarcoma. Now, the significance of it being a sarcoma is, it is not spread through lymphatics. So, cystosarcoma phyllodes, normally you do simple mastectomy. You don't require an MRM. You don't require the removal of axillary group of lymph nodes. In a case of malignant cystosarcoma also, you don't remove lymph nodes because it spreads through blood spread. So when it is spreading through blood, there is no point of removing the lymphatics. So always, whether it is benign or malignant, the treatment of choice is simple mastectomy. Okay, simple mastectomy is the treatment of choice. And here, calcifications do occur, cystic components are present, and it has got a high tendency to recur. Okay, evidences of calcification and necrosis is seen, and the classical appearance on pathological sections is phyllodes, that is leaf-like appearance is seen. That is why it is called as cystosarcoma phyllodes. Okay, a leaf-like pattern on the slides is seen. Okay. Now, the majority of times the treatment is mastectomy only and axillary dissection is not recommended. Trunk flap derives its blood supply from which vessels? Superior epigastric, inferior epigastric, circumflex, internal pudendal. Yes. What is a tram flap? What is TRAM? Rectus abdominis, right, generally used for breast reconstruction. Now, this is a case of tram flap where you remove this transverse rectus abdominis muscle, and this is based on superior epigastric vessel. Okay, sometimes you can also take for the lower quadrant reconstruction. In the case of large breast, you can also take inferior epigastric vessel pedicle also, but rarely done. Okay, generally done procedure is this superior epigastric of the opposite side. For a right breast carcinoma, generally you take a tram flap from here, okay, and rotate it like this. It is not possible to rotate a flap like this, right, where the vessel will get kinked. So you have to always, when it is asked about the question like right or left, you should be ready. Okay, so it is generally from the opposite side that you take a flap, right. Transverse abdominis maintains mainly from the superior epigastric vessels. Best definitive investigation for carcinoma breast. FNAC or biopsy? Okay. Anywhere when it is called as best is always a biopsy. Most appropriate time for cell breast examination is post-menstrual. That is 3rd to 5th day, okay, when the estrogen levels are at its peak. Muzzle flap with segmental pedicle generally is taken from muzzle flap with segmental pedicle. Okay, you have to know what is a segmental pedicle. Okay, I will just explain. Okay, there are some types of flaps. Okay, I will just tell you what are the flaps, types of flaps based upon the vascular anatomy. Okay, so this is type 1. Generally, make a note of this. This is not given anywhere. This is a recent question. This is type 1, which is based. This is based on one vascular pedicle. Type 1, based on one vascular pedicle. Type 2 is based on one major and other minor, one dominant vascular pedicle and other minor, commonly seen in gracilis. Type 3 is two dominant pedicles like gluteus maximus, where you have superior gluteal and inferior gluteal. So type 3 is two dominant vessels. Type 4, again same like this, segmental vascular pedicles. Here one segment, here one segment, here each and everything will be the same, no dominant vessel. Segmental supply will be seen. Type 5, two different complete supplies. Two different, this is different and that is different supply. Type 5. One dominant pedicle and secondary segment. These are the types of muscle flaps with vascular anatomy. Muscle flaps with vascular anatomy. Now, segmental pedicle. Segmental pedicle is commonly seen with sartorius. This is segmental, right? Understood? Type 4 is segmental. Segmental vascular pedicles. Okay, this is of course an advanced question, but still have an idea about this. TNM staging of breast carcinoma with positive bilateral supraclavicular lymph nodes. Sure shot, pakka question. N3 C. Okay. The point to be remembered, bilateral, there is nothing called bilateral in the classification. All ipsilateral only. Okay, let us try to discuss this. Of course, you know the T staging, right? T1 less than 2, 2 to 5 and more than 5. Of course, T4A chest wall, B skin, C A plus B, D inflammatory carcinoma. Now, what are the skin lesions that you find in T4B? Which of the following is not included in T4B? Okay, let me ask you in that way. Skin nodules, ulceration, erythema, PD orange appearance. Yes? Erythema. Okay, there are three important things that are included in T4B. One is skin nodules, edema, ulceration. This was a question asked in some Kerala or Maharashtra. Only three skin conditions: nodularity, edema and ulceration. Okay, all other skin structures like erythema or other things, okay, whatever you find, okay, those are not included. Only these three. Okay, this is regarding the T. N1 ipsilateral level 1 mostly. N2A most likely ipsilateral fixed to one another, axillary. N2B ipsilateral internal mammary loop of lymph nodes only. N2B. Okay. 3A ipsilateral infraclavicular. 3B ipsilateral internal mammary plus axillary lymph nodes. Here only internal mammary. 2B. 3B internal mammary plus axillary. 3C ipsilateral supraclavicular but not bilateral. Okay, on the same side only. When it is bilateral means that is metastasis. Okay, that is a commonly asked question, remember. Okay. Nipple inversion occurs due to the involvement of subdermal lymphatics. Okay, subareolar ducts. Okay, which cause? Now, what is the most common cause of nipple inversion? Yes? Least. No, don't give preference to big things. Big things come only in the late. Most common cause is physiological. Yes, very good. Physiological. Okay, majority of times it is physiological and it will revert back to normal. Nothing needs to be done. Okay. Van Nuys grading system. One more important thing. Van Nuys grading system is used for LCIS, DCIS, inflammatory carcinoma of breast. Yes, L or D. I am hearing only CIS. Which CIS? You are all too intelligent. So whenever I come, generally whenever we take a class and we ask whether it increase or decrease means crease. So that is quite obvious. Generally you do it for DCIS, not for LCIS. All the grading systems, prognostic systems are mostly for DCIS. Okay, Van Nuys prognostic index is mainly used for DCIS, and this is the prognostic classification that you have to remember. So the size, grade, the margins of excision and the patient's age. These are the factors, at least remember the factors which are used in Van Nuys. Size, grade, the excision margin and the patient's age. The factors used in VNPI. Okay. DCIS measuring less than 2.5 with a minimum 1 centimeter margin, okay, is favorable. Less than 2.5 centimeters with 1 centimeter margin, favorable prognosis.